people coming on to watch. Good evening, everybody. We're back again. Just about. If people could put a few thumbs up and things just to let us know that the feed and everything is working okay. Should be able to do that, I think, in the bottom of the image. There we go, lots of thumbs up, a few hearts as well. Wow.
They were from me, Stu.
Oh, yeah. They were from you. Yeah. Just wait a couple of more minutes when we just sort of got to 9 o'clock. At least we seem to be working this time around. Last week it was definitely not quite so smooth. So we've managed to do it at least a little bit smoother this week. So what I'll do, guys, we'll get started. It is 9 o'clock on a Thursday night after all. So we're going to do another session. Tonight is very much I want to say a beginner's session, but a basic session on what we can see on musculoskeletal ultrasound. So hopefully an ideal way for those of you who have no experience or just want to understand a bit more about the topic to get a bit of an appreciation of that, really. We're going to go through a number of different things, and we're going to base it around a PowerPoint presentation that we're going to go through, and each of us will go through a couple of different structures that you'll see quite commonly, or that you'll encounter quite commonly on musculoskeletal ultrasound as well. So we're going to try and do a little share of the screen now, so we can change this over. Okay, so hopefully that's working now. Just going to wait till we just make sure that all comes up on the Facebook feed before we carry on. There we go. Okay, perfect. So what can be seen on musculoskeletal ultrasound was the topic of tonight's webinar. And I thought it'd be nice on a dark, and actually it's been quite a wet day here in the UK, on April evening, to have a nice sunny tropical island to look at. So what can we see on ultrasound? And we'll take you on a bit of a journey through this now, hopefully over the next 45 minutes to an hour. So an attempt at a bit of a structure for the evening, so that we manage to keep ourselves a little bit in check about what we're talking about. So I'm going to just take you through initially what musculoskeletal ultrasound is in a relatively basic sense. We're then going to talk about orientation to the image, and some of the pitfalls, or in fact, actually what tends to be termed an artefact, that is an anisotropy that particularly affects musculoskeletal ultrasound. And then looking at a basic overview, essentially, of normal and pathological changes around tendons, joints, bones, nerves, muscles, and ligaments. And hopefully by the end of that, we will have covered a lot of areas that you'll encounter in clinical practice, but also for those of you who are completely new to the topic, we're at least hoping that you'll go away with a bit more of an idea of musculoskeletal ultrasound than you were at 8:55 p.m. London time. So without further delay, let's see if I can just shift on the slide. So what is musculoskeletal ultrasound? Well, in essence, it's the use of high frequency sound waves to visualize musculoskeletal soft tissue structures. And we know, without going into too much depth, that if we can get a high frequency image, it has a good resolution. This tends to mean more superficial structures. And with musculoskeletal ultrasound, you tend to get a very good resolution of an image at anything up to 4 to 5 centimeters of depth. At that point, you're likely to have to drop your frequency a little bit, and you may lose some of the resolution of the image. It's used for a broad spectrum of things. Multiple joints and structures can be visualized, and we'll touch on that today. And that's one of the main reasons for us, hopefully, to talk you through this. 2 core views. So I've chopped up a banana in the top right-hand image there to try and help you guys understand that a bit more. The longitudinal view, or the long view, as it's often termed within ultrasound, is the banana sliced down its length, and the short axis or transverse view is the banana sliced in a cross-sectional manner. And those tend to be how ultrasound demonstrates structures. In terms of tendons, for example, is a nice one to think of, that longitudinal short axis view. And I will run through that in the tendon section in a second. It's a technically challenging skill. So musculoskeletal anatomy is complex. And when you start to use ultrasound, I think you really start to appreciate that it's actually very complex. And you certainly need to have a very good anatomical blueprint behind you to help you manipulate your probe to visualize structures appropriately. Alongside that, probe manipulation is a real skill in its own right. And we touched on this, I think, last week quite a bit, didn't we, guys, around how to maneuver the probe, the skill of doing that. And Dave mentioned how it's very, very like you playing a musical instrument, essentially. But it's a technical skill ultimately to acquire, and requires training and competency to use it appropriately and importantly, safely. We've mentioned already that you can get excellent resolution of superficial musculoskeletal structures, and this is improving all the time. We're talking about machines next week, but certainly the technology around and the resolution of images has improved dramatically since I've been in and around ultrasound and enjoying it. And one of the nice things about ultrasound in comparison to other imaging modalities is that you can dynamically evaluate things as well. So if I try and play the bottom image there, you can see this is a longitudinal view of the talar crural joint at the front of the ankle. And what you can see there is a loose body sitting in the front there. Now I'm just going to try, he says, with very sweaty hands, trying to get this right. I'm going to try and just annotate that image there so you can see what I'm talking about. This is a loose body here. And you can see, importantly, the key thing with a loose body in the front of a joint, or anywhere, in fact, is that you actually try and visualize it moving independently of the adjacent bone. If it doesn't, then it can obviously be a protrusion of this bone here. But it's not, it's moving independently, and that means it's a loose body. But ultrasound is a great way to dynamically evaluate structures, and certainly with my physiotherapy background, I'm always looking to try and integrate it into the patient's sort of presentation specifically. So if the patient has a particular movement that's uncomfortable or whatever, using ultrasound to get that bit more information to help take the process forwards. So this is just, again, another view here of that longitudinal and short view. It's basically another opportunity for me to show my very innovative, or I felt like it was innovative at the time, chopped up banana on the chopping board. But you can see here, this is a longitudinal view, bottom left, of a finger flexor in the hand. The lovely appearance of a nice healthy tendon there across the image. And this is a cross-sectional view, or a short axis view of a tendon here. I think that's probably the first extensor compartment at the wrist at that point. Okay, so those are just your key two views again, just to recap that. Anisotropy or anisotropy, called lots of different things probably around the world, but it's an artifact, and it's a really important artifact that we encounter with musculoskeletal ultrasound in particular. And it's to do with you being absolutely perpendicular to a structure, or the angle of inclination being absolutely spot on. And this is just an image of me scanning my patella tendon, as I often do on a quiet evening during the week. And you can see here, this blue line here represents the patella tendon, and this is the probe perpendicular to it. The image on the right hand side there, you can see the tendon is actually very bright white and echogenic. This is the tendon here on the screen. It's quite broad actually, and often on courses and things when we're teaching, people are often quite surprised actually how broad the patella tendon is. But you can see it's bright white, it's nice and healthy, much to my relief. But if I then move my probe off that perpendicular angle to the blue line or tendon, it turns dark, or hypoechoic as we term it within ultrasound. And that can often be indicative of tendinopathic change. It would be unusual to have tendinopathic change in this point in the patella tendon, and when you become more experienced, you sort of appreciate that. But it could be termed and could be judged as that, given that image. So anisotropy is a really important artifact, and I think it reaffirms what I mentioned earlier about the importance of probe manipulation training and the skill of creating a really good image, because otherwise your interpretation may not be quite right. And if you think about that, that has a knock-on effect potentially to the patient's management, etc., etc. So this is just a very brief overview slide, and thanks very much to Complete Anatomy at 3D4 Medical for letting us use their anatomy images throughout this presentation tonight. And also, I shared today at 12 o'clock, we've been doing a little thing on the ultrasound site at 12 o'clock, I've been sharing some ultrasound articles. We shared the Galano paper, which is where that ligament picture came from. We had permission to use that from the author. So thank you very much again to them as well. Some fantastic dissection images in that paper. So have a look at Twitter and you'll see the free full text articles linked to it, and it'll be on Facebook as well. But just to give you a very brief overview here, muscle, nerve, tendon, bone and ligaments. I'm also going to cover joint changes with you, and the guys will go through this in more detail, but it just gives you an idea and a flavour of the sorts of things that you can see with musculoskeletal ultrasound and the sort of quality of image that you can often achieve. I'm conscious there's not any questions coming in. There's a few people liking and things. So once I've stopped gibbering, I'll have a look and we'll try and catch up. So tendons and ultrasound. So this is my first port of call for the evening. So a brief overview of tendons and ultrasound. So normal appearances of tendons. These are all Achilles tendons. And when you're starting to scan your Achilles tendon, although it's a bit tricky to scan yourself, if you've got longer arms, it's a bit easier. But it's a nice big tendon to get a hold of and to evaluate. You can see here at the top, this is a longitudinal view. This is the tendon here at the top of the image. Closely packed collagen fibers, making it very echogenic and a nice normal appearance. This is the appearance onto the calcaneus, and this is a short axis view, that transverse view. Think back to the banana, it's been chopped and you're looking up the tendon essentially. Okay, so that's just your normal tendon. Nice classic view really of a mid-Achilles tendinopathy. I'm not going to get into the sort of structure and pain disconnect issue and how pathological structural change in ultrasound doesn't always correlate with pain or pain presentation within a patient. But I will say it's a very, very important aspect to safe, appropriate use of imaging. The purpose of tonight is really just to provide an overview of what things look like and what you can see essentially. So what we're going to look at here is that this is just the thickened Achilles tendon. Normally the tendon width is this kind of width for the Achilles tendon in a long axis view. When you can see here, it's much more thickened than that. Oh, just go on one slide, sorry, let's just go back one. And then a short axis view, again, disorganized appearance of the tendon, thickened and echogenic. That's your kind of normal appearance of an Achilles, okay? So tendons are very nicely visualized, and it's relatively easy to pick up structural change. It's always important, and the guys will probably mention this later, but it's always important to evaluate these changes in two planes, particularly with these kinds of structures. If you see something in one plane, make sure you can find it in a longitudinal or a transverse or vice versa. Really important to do that to confirm your findings, particularly in light of the artifacts we mentioned a bit earlier. Patella tendon, so again, usually the proximal part of the patella tendon. You can see here neovascularity, use of Doppler. Be careful with Doppler. Doppler is very variable between systems. You need to know your Doppler, the sensitivity, and what you can take as a conclusion from it. But often with tendinopathy, there will be some vascular change in the tendon as well. You can get calcification, most commonly seen around the shoulder probably, with varying appearances, with varying levels of density. This is a less dense or maybe sort of a more fragmented appearance of calcification here in a tendon in the shoulder. This is a denser appearance. You can see the shadowing deep to it here, so a denser appearance of calcification. And don't forget the insertions. When I was putting this together, it's very easy to focus upon the big bulky part of the tendon. Don't forget the distal insertion, and rheumatologists who use ultrasound will particularly be keen on this. But you can get some very, very useful clinical information from the distal insertions of these tendons around the region that's often termed the enthesis. So This is a normal Achilles tendon. It's also worth just mentioning that's a normal appearance. It's darker. It's not tendinopathic or pathological change. It's purely the angulation of the distal fibers attaching to the calcaneus there. It's my poor scanning, basically, which is why that is a dark tendon at that point. And these are just two images here just to show some vascularity in the tendon distally, but also some erosive cortical change here on the calcaneus as well, which can be useful as a signpost towards other inflammatory joint conditions potentially. So don't forget the insertion points. Tendons can rupture, as well as we all know. Achilles tendons, quads tendons, patella tendons, I could go on. But this is just an example of Achilles tendons. So you can see here, nice view of the Achilles. This is one end of the tendon. This is the proximal part of the calf or the Achilles complex, and this is the distal aspect going down to the calcaneus. And you can see in the middle here the defect. A couple of top tips around this. Measure the gap in equinus as well as in neutral to see how close those two ends come back together. That can help the surgeons in their planning. Consider the presence of hematoma in that gap, which can also prohibit healing. And also just be aware of plantaris. This can be a bit of a pitfall when you first start scanning Achilles tendon ruptures. They're not always that easy to work out. And sometimes you can see these remaining fibers, and that's not the remaining fibers of the Achilles, that's just the plantaris that's dropped into the defect. Okay, so just be aware of that. And I've mentioned an oblique defect. These tendons rarely ever just break straight like that. They tend to break in a more messy way or an oblique way. So always ensure you visualize the structure all the way across. Tenosynovitis. So tenosynovitis, as we know, is to do with inflammation of the sheath surrounding the tendon, essentially. I'm going to play these videos now, hopefully. There we go. Got a bit excited with this slide. So you can see here pockets of fluid surrounding the tendons. Very light probe pressure. If you put too much pressure on the probe, you will flush the fluid away and it will look normal. These are all finger flexors at the hand. You can see fluid here deep to the tendon in the sheath. All examples of finger flexor tenosynovitis. Again here, and again, a little bit of fluid here. And you can see here the gel standoff, which means that my pressure is very, very light at this point around the tendon. Without any gel standoff, you would be flushing that fluid away and making different conclusions. So we can certainly see tenosynovitis or inflammation of the sheath as well very nicely on these things, on the ultrasound images. Tib post tenosynovitis, so same thing, lower limb. Thought I'd put a bit of a spread in there for people. Commonly affected tib post tenosynovitis from mechanical problems, but again, also from inflammatory joint conditions. Again, you can see pockets of fluid here around the tendon. And again, in this longitudinal image, bottom left here, again, fluid adjacent to the tendon within the sheath, all indicative of tenosynovitis. Little top tip here, when you're doing rheumatology scanning, a decent amount of it anyway, just get used to picking up synovial hypertrophy or thickening of the sheath. Can be miscalled as part of the tendon at times. So tib post tenosynovitis as well. Joint appearances, reasonably quickly going to whiz through these ones. Degenerative joint changes, nicely seen on ultrasound. So bony hypertrophy around the joint margins here. You can see this is the first CMC joint. This is the volar aspect. Often you can see things a bit nicer around the volar aspects actually of the first CMC joint. But bony hypertrophy here of the joint margins and thickening of the joint capsule with some Doppler activity there as well. Erosive change, so inflammatory joint conditions, erosive change around the joint margins. Again, nicely visualized in ultrasound. Does take a bit of mileage. You need to understand the normal cortical outlines of these joints to really be able to confirm an erosive change. They tend to have quite a distinct appearance, as you can see here. This is an erosion here, a very, very defined appearance. And they tend to have quite classic locations as well, which helps you make that call. But you can see erosive change reasonably well on things like X-ray, but ultrasound is much more sensitive at picking that up, particularly in an early stage. And obviously that can help with patient management. And last slide for me, so joint changes, joint effusion. So again, a few rheumatology focused things here, but certainly you can see joint effusions very nicely, and that's helpful sometimes to enhance your clinical assessment. If you're looking at a patient and saying, is there an effusion, is there not an effusion, comparing asymptomatic to symptomatic sides. Top right is ankle synovitis, very, very distinct. Don't often see it that clear. And bottom right is a joint synovitis, a knee synovitis. And the particular point I want to raise here was this is all free fluid. So on ultrasound, you can compress that, you can squash that. But this is interesting, this thickening of the lining of the knee capsule here. This synovial hypertrophy is very, very distinctive in this image for synovitis of the joint. So lots of interesting things you can pick up around joints as well. So I'm going to hand over now to Rob, who's going to take you through some of the bony appearances. Rob's going to just give me the nod during the PowerPoint, and I'm going to shift him on a slide when he wants me to. So over to you, Rob. Well, we seem to have lost. Hang on a second.
Unmute. Yeah, that will work. You okay?
Yeah, go for it, Rob.
Yeah. Yeah, so hi. So I'm going to talk around what we can see in terms of bone appearances. So Stu, you can go to the next slide. So yeah, effectively, what happens with an ultrasound beam hits a bone at a 90-degree angle, you get a very sharp interface, because the soft tissues that overlie the bone, and the bone is obviously very dense and reflects a lot of the ultrasound waves directly, but it's also very different in terms of its density to the soft tissues that overlie it. And if any ultrasound wave goes through tissues of two very opposing sorts of densities, then it creates this very, very sharp, bright white line. And that's basically, if you're scanning a bone, and that is why the bone will always be very, very bright. And obviously, if you're imaging a long bone, not at the joint level, then it's a very nice and straight and smooth white line. And that's what you would like to see, and that's what a normal image is like. Because it's so dense, and it's so hard, you can actually sort of see that very clearly in the images. Next slide. So what happens, obviously, if there is a interruption, a fracture, then we see a very abrupt change, and that's typical, and that's something that actually might take a little bit of experience as well for people to appreciate, because when you first scan, you might see some cortical irregularities, and you might actually take that as an interruption of the cortex, but it might actually be a small erosion or something like that. And because ultrasound is so sensitive, it can pick up very small changes, and it might be misinterpreted often, particularly when people are quite new to it, that do not see that. But particularly if you've been scanning for a while and you start sort of looking at patterns, and obviously with bones, you can see two sides of the fracture quite often. And sometimes if you scan around the bone, you can follow the bone in a three-dimensional direction, and you can actually see where the fracture is. So you look at the step off, and you then also look and see if there's any sort of forward projection of bone relative to the remainder of the bone, and that then quite often is very much like a key element. I just wanted to touch a bit about the accuracy of ultrasound in evaluating bone, because it's not something I think that traditionally is thought of as like the main modality to evaluate bones, because that's more X-ray. And to be fair, it still is, because X-ray is the modality of choice really to evaluate fractures. But there's quite a body of evidence now, and I have done some studies to show that there's been about there's a randomized controlled trial was done in 2013, And I might want to go to that slide now, Stu. I think I have that in there. You might have to skip through that, sorry. I'll come back to the other ones. Yeah, here. So a randomized controlled trial and that demonstrated very clearly that there was quite a significant sensitivity and specificity to ultrasound in detecting fractures. But you know, in some cases, it was actually higher than X-ray because the X-ray might not pick certain fractures, for example, of the femur up in maybe there might be a 10 or 15% rate of failure to pick up, and sensitivity might be quite low for certain types of X-rays. And ultrasound is obviously also not hugely high, but it is, you know, it could be something like 94, 95%, which is fairly acceptable in most modalities. However, they concluded that although it's a very powerful adjunct, it has to be seen still as an adjunct. But they also said that this can be used in, for example, settings where there is no X-ray available, like, for example, in third world countries, actually as a very reliable and fairly sensitive modality to evaluate for fractures. Okay, so Stu, we can go back again to the slides beforehand. Yeah, so now these are really nice images of the greater tuberosity. Now, and if you look at that video clip at the bottom, where you can really nicely see that on both sides, on the left and right, you can see that protruding lump of bone, and you can see that real sharp angle on the left, and as you scan through it, you can also see it on the right. And that again is typical of an avulsion fracture, where a piece of bone, if you like, has sort of slightly moved forward and sits a bit proud of the rest. And that's obviously something that ultrasound of greater tuberosity fractures is something that is a very, very basically it's the most obvious fracture that we come across in musculoskeletal outpatient settings, because you know, fall on shoulder is a very common diagnosis. Quite often it's mistaken, and it's very often it's something that does get referred to physio, and it's something that, you know, might be thought of as potentially a rotator cuff tear. And then when you scan these people, in many cases you find that it's actually a bony abnormality, and it's not the rotator cuff itself that is the problem. So in that case, you see this, I would say, very, very frequently. Okay, next slide. These are some nice other slides. Again, some bone changes. This is, you know, some in the center image. You see there is almost like a fragmented demonstration of a, I think it's a metatarsal head or something like that, and it's a fracture. So again, these quite sharp steps, and you see the sort of fluid that then also quite often is something that the bleeding, etc., is something that can be seen. But these ones are kind of intra-articular, so then you get sort of fluid because of that as well. Okay, and next slide. Yeah, and now we have done that, then we go to the nerve. So nerve ultrasound is something that I think is something that we find it's very interesting. It's an area that we can see quite a lot, and nerves are quite unique structures. So we quickly go through the structures of nerves. So basically, you have to see the nerve as a sort of container, and the mesoneurium is the kind of sheath, if you like, that sort of contains the sort of entire nerve. And then you have within that, you have the bundles of nerves, and these are fibers enclosed by, again, slight, smaller, thinner, like sheaths surrounding these fibers. And inside of those smaller bundles, you have the fascicles. And the fascicles are actually what conducts the nerve pulses, and they're kind of different type of structures in the sense that they're not as compressible and not connective tissue. And obviously the structures that I mentioned, the epineurium, the perineurium, and the mesoneurium, those are all connective structures, and that has consequences because an ultrasound, they will show quite differently. So next slide, please. So now this is a nice little diagram of what a normal nerve in the, if you see the diagram on the left hand side, you see a normal nerve has these fascicles, these black or dark on ultrasound. As you can see the image above, you can see them so nice and dark, but you see in between those dark fascicles you have the connective tissue, and the connective tissue is showing quite bright. So a normal nerve would show very bright for the connective tissue and almost black for the fascicles. Now, as you can see on the right hand side, edematous nerve shows very different because the fascicles themselves actually become edematous and swell up, and because they're already dark, they're going to take up even more space within the sheath, and therefore the overall appearance of the nerve becomes darker still, and the connective tissue is actually pushed away a little bit, and that's why you get that typical darkened image of the nerve. It's a hypoechogemic, and also quite often because of the edema, it's a lot bigger, and that is very much an abnormal nerve. You can see we have some more images of that in the next slide, I think. Yeah, now this is another feature of nerves that I also wanted to touch upon, because I did use the analogy of an electric cable. So let's say you have I don't know, coax cable, something that you use for the TV, that's got quite a thick plastic container, yeah, but it's also, you can squeeze it, and quite often you can squeeze it, and actually the metal smaller cables inside, they're kind of quite often wrapped in the individual little sheets, but they can kind of spread out through the flattened plastic container, and therefore you don't actually damage the individual like cables or the current carrying cables at all, because the images or whatever it is are not affected, because they're kind of very hard material. It's like copper, or it's like fiber optics, or whatever it is, but it is quite hard. It's the surrounding stuff that you can compress, and that's exactly the same with nerves. So if you have a normal peripheral nerve, even if you compress it slightly with your probe, you would see that the nerve almost collapses, but it flattens, and that's exactly what you can see on the right hand side in that image. So yeah. Now, in terms of the structure and the characteristics of the nerves, that is also something that again is quite unique and different to other structures. So for example, nerves that run in areas of where they either cross a joint, let's say the wrist or something, or they kind of run alongside a long bone, but they're not proximal but more distal. Those nerves or nerve fascicles run in a very parallel format, so they're very segmented, and there's lots of them as well. So that's why, for example, if you look at the median nerve at the wrist, you can see a huge number of fascicles surrounded by the epineurium, and it looks very clear, very bright, and very black and white, if you like, the honeycomb structure, the classics of nerve structure. But if you go in areas where there's pulleys, or areas higher up, for example, nerve roots in the spine, they are usually composed of only a few fascicles, or a few fascicles with very little epineurium, and therefore they show dark. Now, it took me quite a little while actually to work out that that is why, for example, the ulnar nerve in the cubital tunnel, and that's what the example is on the right-hand side in the top, is actually not an abnormality. I always thought it meant that this nerve was particularly abnormal because, you know, it was not particularly echogenic. You'll find that in most people it is like that, and that is actually quite normal because of the nerve orientation and the structure at that particular level, which is different to what it is like further distal. So yeah, next one. Yeah, and yeah, we're going back here again. This is probably a slide that I should have. Nevertheless, this again goes through the honeycomb structure. So in cross section, you can see very clearly. You can see black and white honeycomb structure.
Just losing you there, Rob, a little bit.
On the right-hand side is you can see that in your section, that's another thing. As the segment.
Oh, I think we've lost Rob a bit there.
Me, yeah.
Yeah, we lost you there a bit, Rob.
Okay.
I think we can just about. Can you
hear me?
Yeah, we lost you there.
Interrupted?
Yeah, we've got you back again now.
Okay.
I'll move you on to that next slide.
Yeah. Okay. Cool. Yeah. So yeah, we're looking at pathology now, and the median nerve, as I said before, when nerves become compressed, they become hypoechogenic and thickened, and you can really beautifully. This is a really nice image actually. So you can really see that where the nerve is not compressed, and it actually is relatively normal in terms of size. It also is very normal in terms of the echogenic structure. So it gives you that bright and dark intermingled image that you would expect of a nerve. Whereas when you see that it becomes much bigger further down or further up, wherever it is, you see it becomes darker. And the corresponding longitudinal image is on the right-hand side. And yeah, ultrasound is helpful, particularly using for things like carpal tunnel syndrome, because measurements are kind of usually able to be reproduced and therefore help with the diagnosis. I think we're going to Dave then now.
Hi, thanks, Rob.
Good. Okay.
So I'm just going to be talking a little bit about muscles and their appearance on ultrasound, and just talking through some of the basics around muscle injury and how ultrasound can be sort of utilized in their assessment. Can I have the next slide, please, Stu? So just quickly, a refresher on the anatomy of the skeletal muscle. And we can think of it almost like the sort of Russian doll setup, where you've got the sort of fascicles that have got the endomysium surrounding them, and then they're gathered into bundles, and you've got the perimysium around the bundles, and then surrounding the whole muscle sheath is the epimysium. Now, on ultrasound, it's really the perimysium predominantly that you're looking at that gives the muscle its very sort of typical architecture, and how we tend to sort of look at muscles in terms of its grayscale appearance compared with other tissues. So if we just go on to the next slide, please, Stu. So this is a sort of classic image here of a muscle, and you can see here the arrow at the top is showing you the epimysium, so the relatively hyperechoic surrounds of the muscle. You can see also here the striated perimysium. So here we're looking at the muscle in sort of longitudinal view, and you can see these really lovely stripes showing you the direction of the muscle. And it's very typical of a muscle appearance. Allows us very nicely to identify not only also the direction of the pull of that particular segment of the muscle. So where we've got bipinnate muscles or complex muscles, and oftentimes we get sort of angulations and diagonal patterning of the perimysium of the muscle. If we've got a simple muscle, then oftentimes the perimysium are laying just in a sort of straight longitudinal plane. We go on to the next slide, please, Stu. So here, got a really nice image of the aponeurosis of the calf. So where we can see the, Stu, if you can just run our little laser pointer along the aponeurosis. So here we're seeing essentially the aponeurosis between the gastrocnemius muscle, which sits superficially here, and you've got this sort of classic image of the as it sort of gradually gets more and more narrow and eventually blends into the aponeurosis at the top here, that's going to go off and sort of form the most superficial part of the Achilles tendon, just to orientate ourselves there. And sitting deep to this, we've got the soleus muscle, and we can see here how the image of the soleus is quite different. And this is just due to how the different fiber bundles within the soleus are organized quite differently from the gastrocnemius, and the way the organization of the perimysium gives it a distinctly different appearance. And we'll see this as well in some of the other images as we go through. We go to the next slide, please, Stu. So one of the things that I think you really start to appreciate with ultrasounds is that muscles and most other structures, they don't tend to sort of tear or disrupt in sort of some random point in the middle of a muscle. It's almost always around an edge or an attachment. So we can see here that the muscle has kind of almost evulsed away. If you look at the dark area there here, the hypoechoic area, if you can just outline that, Stu, with the laser. So here is the hypoechoic region where the muscle is torn, and this will be now filled with the hematoma, and the fibers of the muscle have pulled away or avulsed away. Nearly all muscle tears, unless there's been a penetrating injury, will occur where a muscle attaches onto an aponeurosis or a musculotendinous junction. You almost never see a tear just occurring randomly within the belly of a muscle. I don't think we ever see that. It's always an avulsion away from an attachment or an away from a joint. We go on to the next slide, please, Stu. So here we're looking at a cross-sectional image, and here we can see again sort of hypoechoic area, hypoechoic region, hematoma here, which is occurring between the gastroc and the soleus here. Go to the next slide, please, Stu. So there are a number of different grading systems for muscle injuries, but typically your grade 1 is either a strain, so no actual disruption to the muscle fibers, or a very small amount, so less than 5% oftentimes is would be the size of the tear. So a very, very small disruption in the actual muscle fibers itself. A grade 2 or moderate tear can really be, depending on which system you're following, can really span anything from, just a very small percentage, 10, 15%, up to quite a significant amount of disruption of a of the muscle. And a grade 3 normally talks of a complete rupture or a complete avulsion of the muscle, but there is a degree of lack of congruency, if you like, between the different grading systems. And oftentimes the grading systems will talk about functional tests as well as the appearance on ultrasound or MRI scan. And so oftentimes if you're just relying on scan alone, it doesn't really tell you the sort of full picture. So we tend to give a little bit more of a description of the tear when we're scanning, rather than just saying a grade 2 tear. We would tend to give a little bit more information about the exact appearance of the tear. We go on to the next slide, please, Stu. Okay, so if we start thinking about the ligaments and how ligaments appear on ultrasound, we go on to the next slide. So ligaments are collagen structures that run between bone and bone. They are oftentimes quite easily visualized. A large number of ligaments around the body are very easily visualized on ultrasound. And here we can look at, as Stu is depicting with his laser pointer, this is the very typical, again, looks not dissimilar in appearance to a tendon, in terms of it tends to have that sort of very typical hypercoic sort of fibular appearance, but in this case we'll be running from one bone to another. And the beauty with ultrasound is the ability to be able to dynamically stress and to put torsion on ligaments so that we can see whether or not they're intact. Probably, or certainly a ligament, area of ligaments that really lends itself to ultrasound are ligaments around the ankle. We see lots and lots in clinical practice of lateral ligament injuries. So here we're looking at the anterior talofibular ligament. Also really important to assess high ankle sprains, so the anterior inferior tib-fib ligament. And ultrasound really comes into its own, I think, on such structures, because it allows you to perform dynamic stress tests to see whether or not you can actually cause gapping between the bones. You can oftentimes see the stubs of the ligament pulling apart from one another. We can look in also for signs of effusion. So it really gives you lots and lots of information when you're assessing ligamentous injuries. Go to the next. So I think this is actually a little video. So we can see here the anterior talofibular ligament is being stressed. And we can see here the ligament is nicely intact. It goes from quite a lax position and then can be torsioned. We go to the next slide, please, Stu. So here we're looking at a ruptured anterior talofibular ligament, and so here we can see evidence of some effusion. Also, we see some of the sort of debris, the stub of the ligament that was intact. We can also see how the surrounding connective tissue is no longer being sort of held up and away, so you're losing the normal margins and the normal compartmentalization of the tissue around that particular area. You can see also on the lower picture looks like there's some signs of some sort of minor sort of cortical changes there. So oftentimes you'll see evidence with a ligament injury. There's oftentimes some degree of disruption at the attachment sites as well. It's very typical, as well as significant sort of effusion in the area. And as we said, with ultrasound, we're really able to demonstrate the lack of integrity, the gapping of the two bony structures. If we go to the next. Another ligament on the lateral aspect of the ankle. So this is quite a neat assessment technique. So the calcaneofibular ligament here can be seen running, and it sort of dips slightly away from the probe. So it's difficult to obtain a good image of the whole ligament without getting some anisotropy. If we look on top of the ligament there, we're actually looking in cross section at the peroneus longus and peroneus brevis tendons. Now here they look almost like a little coffee bean or a little yin and yang sign. And as you tension the ligament, you'll see that the tendons are actually lifted up and away by the ligament. And this is a sort of dynamic test, quite a clever little test, because it demonstrates the integrity of this ligament by way of actually lifting the two tendons up. So it's a nice way of being able to assess the integrity of that particular structure. Go to the next slide, please, Stu. So other ligaments that we will commonly assess on ultrasound, we see lots of medial collateral ligament injuries at the knee, and here with ultrasound, or here we were looking at the sort of anatomical slice, as it were, and you can see here the superficial layer of the medial collateral ligament, and then deep to that you have the meniscal femoral ligament and the meniscal tibial ligament depicted on our image there. If we then go to the next image, yeah, so you can see the different layers of the medial collateral ligament on ultrasound. So it gives you an idea of the of just how clearly some of these structures and the detail that you can obtain with ultrasound when you're looking at these structures. So you can really look at the, if you like, the differential between grading of MCL injury, also seeing, you know, to which layers of the MCL does the tear actually penetrate. So also we're seeing that little triangular wedge, if you can just hover over that, Stu, which is the medial meniscus, so the medial aspect of the medial meniscus. And so oftentimes here, if there has been an injury in the anterior medial compartment or medial compartment, you can oftentimes see evidence of some changes within the medial meniscus there. Now, if you go to the next slide, please. Okay.
Real. I think we're pretty much there. Thanks, Dave. We've lost Rob during the evening to a Wi-Fi disruption, basically. So it's just me and Dave that are left.
We've been trying to do that for years.
Yeah.
Finally.
we've managed to shed him, but he's back on the Facebook page, so he's there. Yeah, so thanks very much, Guy. Hopefully that was useful and interesting to you all. So an overview really of just some of the structures that you can see on musculoskeletal ultrasound. I'll just stop that for a second. So yeah, have a look. We're going to share some articles off the back of that on the various social media channels probably tomorrow. Send us any questions on the Facebook feed, on the comments feed next to this video. We'll keep an eye on that and come back to you. And next week, we're looking at evaluating machine choices for ultrasound. So certainly I found when I was getting involved in ultrasound initially, absolute minefield of trying to work out what sort of machine you need, different types of machines, loads of different providers. So we're very, very lucky to have Douglas Ogg join us next week, who's a real expert in this area from many years in the industry to hopefully come on board with us. And we're going to ask him some questions around machines, and he can we can discuss it.
Just a thought. Sorry, just a thought. If people have got any particular questions, particularly for Doug ahead of next week's webinar, what's the best way for people to post them on to you?
Maybe if you you can either stick them on this this thread here, or if you want to email in some particular questions to the website, it's probably the easiest thing. So either use the contact form on the ultrasound site, or drop an email into us at info@theultrasoundsite.co.uk. The details are all available on the website. That's a really good idea, Dave. yeah, if you want to drop in some questions in advance, because it's often a very popular area for discussion for people to think about lots of different aspects. So this will be a lot of live and recorded now on Facebook, and there's also a new page on the website for MSK Ultrasound webinars, where we'll be adding a few days later a version onto the website for you to watch at your convenience as well. And it'll also be an audio version, although I appreciate tonight is predominantly heavily reliant upon the sort of visual slides that we've used, but there'll be an audio version on Spotify and soon to be iTunes as well, hopefully in the coming weeks. But thanks again for all of you who have joined us. Thank you from Uruguay. Christina, thank you for coming from Uruguay to join us tonight. But hopefully, guys, that gives you an hour of interesting content, which is usually quite a challenging time for all of us at home. But hopefully this gives you a bit of information, a bit of stimulation and education. And we look forward to seeing you all again next week. Anything else to add, Dave?
No, look forward to seeing everyone next week. And I suspect it's going to be a barnstormer with Doug here as well. So a real opportunity to pick his brains.
And we'll try and plug Rob back in as well for next week.
Maybe not.
Thanks very much, guys. Take care.
Bye-bye.